All right, so now we get to do the fun part. We are almost at the end of our white blood cell unit, so let's wrap it up with some review, go over our flow charts and our case studies. However, prior to watching or listening to this presentation, please go ahead and complete your flow charts and your case studies to the best of your ability. If you would like to work in groups, I'm okay with that. However, it is to your benefit to really try to work through these case studies so that you kind of understand the diagnostic thought process as we evaluate laboratory values and connect the dots between disease states and labs. Okay, so first up, we are going to look at our non-malignant white blood cell disorder chart. It's not really a flow chart, it's more of a graph chart. But let's kind of talk about some of those. Now, when I say non-malignant, it doesn't necessarily mean that there aren't any health or consequences of health. This just simply means it is caused by something outside of a malignant process. So first one is going to be neutropenia, and of course that's just going to be the absolute decrease in circulating neutrophils. Again, it can be due to a variety of reasons. It can be due to bone marrow insufficiency or suppressed bone marrow. It can be due to a bacterial infection. Remember, we talked about that transient neutropenia, where neutrophils leave the circulation, move out into the tissues to help fight infection. And there is a window of time or a period of time between the migration of neutrophils from circulation into the tissue and the amount of time that it takes for the bone marrow to compensate. So if you were to draw a patient sample in that very window, you would find them to have transient neutropenia. Now, in the case of a bacterial infection, we would treat those infections with antibiotics. But if we were to find that the cause of the neutropenia was due to insufficiency in the bone marrow, we would give granulocyte colony stimulating factor, which is just kind of a little wake up, puts a little pep in the step for our bone marrow. Normally, this does not make patients more prone to viral or fungal or parasitic infections, and that's because we have other white cells that function in that specialty or area of specialty. So viral is going to be associated with our lymphocytes, fungal is going to be more associated with our monocytes, and then our eosinophils are going to be really impactful over those parasitic infections. But all of them can kind of overlap depending on what you find. Okay, excuse me. Shidai-Kagashi syndrome. Shidai-Kagashi syndrome is going to present with neutropenia along with dysfunctional phagocytic activity due to depressed chemotaxis and delayed granulation. One of the characteristic findings that we will see in patients with Shidai-Kagashi syndrome are giant lysosomal granules in the leukocytes and platelets. Unfortunately, the prognosis for these individuals is usually very poor because they die of infection early in childhood. And Staph aureus is commonly indicated in about 70% of the infections. So, chronic granulomatous disease is failure to activate that respiratory burst due to that cytochrome B. We're going to find granulomas. That's one of the characteristic findings. And we will just treat the underlying infections. This is going to result in neutrophilia, not neutropenia. Next, we've got Alder-Riley anomaly. What we're going to see in Alder-Riley are precipitated mucopolysaccharides that can be found in Hunter's and Hurler syndrome. The interesting thing is that these precipitated mucopolysaccharides do resemble toxic granulation, but they stain with a metachromatic stain, which we didn't really talk too much about what that is. But the other way that you can tell the difference between Alder-Riley and toxic granulation is Alder-Riley is a permanent fixture in those granulocytes. It might look like toxic granulation, but toxic granulation will eventually go away in the case of if there's an infection or it's once that infection is gone, the toxic granulation goes away. Whereas with Alder-Riley anomaly, we see it throughout the course of the lifetime of those white cells. Again, we're going to treat the underlying disorder, but there is a poor prognosis for Hunter's and Hurler syndrome. So overall, it's not great news for those patients, unfortunately. And then the last one on our list for this slide is our May-Hagelin anomaly. This is going to be a genetic mutation which affects the megakaryocytes and platelets. We are going to see those giant pale blue cytoplasmic inclusions that again resemble Dolly bodies. And we're going to see giant platelets that kind of dominate the platelets in the peripheral smear. So obviously patients who are having defective or mutated megakaryocytes or platelets are going to suffer with thrombocytopenia as well. So we would treat thrombocytopenia as needed with platelet transfusion, etc., just to ensure that the patient doesn't become prone to bleeding. Okay, so moving forward with our non-malignant white blood cell disorder chart. Next on the list is myeloperoxidase deficiency. If you recall, myeloperoxidase is one of the enzymes present in the granules of both our polys and our monos. Even though monos are considered to be agranulocytes, they still contain very small granules, and some of those granules actually do have myeloperoxidase present. Usually it's a pretty benign complication, or with usually pretty benign with no complications. And that's because myeloperoxidase is not the only enzymatic method that our neutrophils and monos use to break down bacterial infections. Next, we have leukocyte adhesion deficiency. Leukocyte cell surface adhesion proteins are completely absent, and unfortunately for people who suffer with this disease, it is fatal without a stem cell transplant. And that is because, again, without those cell surface adhesion proteins, you can't get to where you're going because you cannot leave the circulation, because you cannot attach to that endothelial lining, and then you cannot move to site of infection and you won't be able to release your granules. So nothing's really working for those white blood cells that have that defect. Next we have Pelger-Hewitt anomaly. So a true Pelger-Hewitt, if you remember, is congenital, and there can be secondary Pelger-Hewitt, secondary specifically to drugs, leukemia, myelodysplastic syndromes. And what we might be looking at are bilobed or non-segmented nucleus in those what would otherwise be segmented neutrophils. It's really not anything that's going to cause a lot of problems. However, it can be a sign that there's an underlying condition, such as that myelodysplastic syndrome. So ultimately, although it doesn't affect the function of the neutrophils that are affected, it does wave a red flag that maybe there's an area we need to investigate to make sure that, number one, we're not looking at a left shift, and number two, we need to determine whether it's true Pelger-Hewitt or if it is caused by some other underlying condition. All right. Gaucher's disease is that beta-glucocerebrosidase deficiency. We see those Gaucher cell in the bone marrow, those histiocytes with kind of crumpled tissue paper appearance. For the most part, prognosis is pretty good. Most of these patients live a relatively normal life, and if there are symptoms associated with this Gaucher's disease, then we just kind of manage those symptoms. And then, of course, this is found pretty often in Ashkenazi Jews and Swedish populations. So there is a definite genetic component to it. The next condition or disorder is Niemann-Pick disease, and this is due to a sphingomyelinase deficiency, and this is also considered a lipid storage problem. A lot of patients have a poor prognosis. There are some newer drugs that can help slow the disease, but we are going to be looking at things like central nervous system degradation, um, neurological impairment, lymphadenopathy, pigmentation, hepatosplenomegaly, and overall growth retardation. So failure to thrive in terms of physical growth. In Tay-Sachs disease, we are going to look at those at the cause is going to be hexosaminidase A deficiency. There may be vacuolated lymphocytes in the peripheral blood, aka foam cells, and then vacuolated histiocytes in the bone marrow. Most of these patients or children die by the age of 4, and again, some central nervous system degradation, red spot in the macula of each eye, macrocephaly, lack of startle reflex, deafness, blindness, seizures, and potential paralysis. So it's really an unfortunate thing. And then last but not least, sea blue histiocytosis syndrome. We're going to see those striking blue histiocytes in the bone marrow, and most patients have a pretty normal lifespan. There may be some splenomegaly, hepatomegaly, and thrombocytopenia, but we just treat those symptoms on a base-to-base case or case-to-case basis. So anyway, that concludes our non-malignant white blood cell disorder flow chart. I hope that that was helpful. If you have any questions, feel free to email me or ask me if you see me in class. Okay, let's take a look at our leukemia flow chart. So first thing we're going to do is we are going to break our leukemia into 2 categories. We are going to have our acute leukemias and our chronic leukemias. Now, if you recall back when we were talking about how to determine whether or not we were looking at an acute leukemia or chronic leukemia, we know that that line drawn in the sand is 30% blasts in the bone marrow if you're going by the FAB, and 20% if you're looking at the World Health Organization criteria. But for the most part, we're going to say equal to or greater than 30% blast in the bone marrow would lead us to believe that we are looking at an acute leukemia, and then fewer than that, we are going to be looking at a chronic leukemia or maybe even a chronic leukemia or in transition, because sometimes chronic leukemias can transition into acute leukemias. We have then a further breakdown. Are we looking at a lymphocytic line of proliferation, or are we looking at a myelocytic line of proliferation? So let's start first with our acute leukemias. We are going to have ALL in terms of our acute lymphocytic line, and then our AML is going to be associated with our acute myelocytic or myelogenous line. Now, both of these categories, acute lymphocytic and acute myelogenous, are further categorized and broken down into classifications. They are not the same though. So let's talk a little bit about ALL. So some of the cell types that we're going to see and the characteristics of ALL are primarily lymphoblasts and some prolymphocytes. We are going to look at our cytochemical stains. Our TDT is going to be positive because remember that stains positive on our lymphocytic leukemias, and then our PAS is also going to be positive. In terms of patient population or demographic, we see ALL more commonly in children. In fact, ALL is the most common type of leukemia that children are diagnosed with. That doesn't mean that adults can't have ALL, and that doesn't mean that kids can't have AML. But for the most part, we think of ALL as more associated with a younger or pediatric demographic. Again, those classifications for ALL are going to be that L1, small uniform, L2, large heterogeneous cells, and then L3, prominent lymphocytic vacuolization. All of those things are going to be considered. Now remember, our L3 category can cross over into some of our lymphomas, so keep that in mind when we get to our lymphomas. Treatment for these patients are typically going to be chemotherapy, radiation, and bone marrow. Bone marrow is going to be the only way to really completely wipe it out for the most part and have the best prognosis. However, younger people tend to have better outcomes with bone marrow than older people do, simply because a lot of times with the process of getting ready for a bone marrow transplant, we have to go through extreme chemotherapy or high doses of chemotherapy, maybe even some radiation, and prior to the bone marrow to kill out that malignant bone marrow that's present. And unfortunately, a lot of older people have comorbidities, poor health in other ways, and they just don't tolerate that process very well. Whereas a younger person who is healthy in every other way, aside from the fact that they have leukemia, is more resilient. All right, let's talk about AML. So our AML is a little bit more complicated. If you think about it, we have more types of myelocytes than we have lymphocytes, so that makes sense. Our primary cell types are going to be myelo and monoblasts with possible Auer rods. We are going to see Sudan black B positive with our cytochemical stains and our myeloperoxidase positive. One thing you really want to pay attention to when you're looking at cytochemical stains with AML is you're going to want to look to see what your CBC results tell you in terms of the cell populations that you have in your differential. That's going to put you in the right, kind of give you some information that will help steer you in the correct direction when you go to classify them. And it'll also confirm your findings when you do those cytochemical stains. You want to see if that matches your suspicions. We're also going to have specific esterase is going to be positive, and then non-specific esterase may be variable. And again, this is going to depend on, do you have a cell population that is 100% myelocytic, or are you going to have some variations? You're going to have a few myeloblasts and then a few monoblasts if, for example, in a myelomonocytic AML. So those things are important to take note of. Again, AML is more prevalent amongst adults, and there is an increased incidence as people age. However, children can get AML. It's more common for them, however, to get ALL. Okay, so in terms of our AML classifications, we have M0 to M7. The first one is going to be myeloblastic without maturation. This is going to stain negative for all cytochemical stains. Even though it is myeloblastic or myelocytic, the stain does not take. And then we might have myeloblastic without maturation. This one will take a couple of the cytochemical stains, so refresh yourself on that. And then we have myeloblastic with maturation. And in this case, we are going to, and this is M2, we're going to see a cytogenetic mutation, a translocation actually on 8 and 21. And then this is also, just to take note, the most common type of, or the most common type of AML. We might also see promyelocytic. And then the myelomonocytic is actually the second most common. So think about what types of cytochemical stain patterns you might have in association with those cell populations. M5 is going to be monocytic, and we have that translocation at 9 and 11. And then M6 is going to be erythroleukemia, which is going to be a proliferation of the erythroid line. And then last but not least, M7, which is a megakaryoblast. Now, we haven't really gotten too much into, we haven't gotten into our flow chart about myeloproliferative disorders, but if you think about how myeloproliferative disorders have the tendency or the ability to transition into acute leukemias, this would be an associated with that association with that erythroid proliferation. And then M7 could be associated with that megakaryoblast or megakaryocytic proliferation. So keep those things in mind when you're going through these flow charts and your PowerPoints. Try to make the connections. Ask yourself, what am I looking at? What information do I have? What other testing can I do to get more information? What disease states do I know of that could present in this way? And just really go through that whole thought process until you get to eliminate everything else except for maybe one or two, and then you really can look at the fine details to make your most educated answer. Moving on from acute leukemias, we're going to have a chronic leukemias, which are a little less nasty. I'm not sure that any one of you would want to have a chronic leukemia, but if I had to have a choice, I would definitely take the chronic over the acute. So with regard to a general term or general statement about leukemia, chronic leukemias, we're going to see a more mature cell population. Now that doesn't mean we won't see immature cells, they just won't be blasts. This is more common in adults, and again, higher incidence as we get older. It has a more gradual onset and a very, very elevated white blood cell count, but overall the prognosis is much better than an acute leukemia. Okay, so again, we're going to classify our chronic leukemias into a lymphocytic line and a myelogenous line. First thing we're going to see are those mature B cell lymphs, smudge cells, and those soccer ball lymphocytes. Because this is so gradual in terms of its onset, we pretty much just give supportive therapy early on, and then once a patient becomes more symptomatic later on in the disease phase or the disease state, we could then knock down that proliferative population with chemotherapy. Our next chronic leukemia is going to be our chronic myelogenous leukemia. We're going to see a lot of granulocytes in their immature forms, but the majority of them will not be blasts. They will be a variation of the different maturation phases that we see in myelocytes or in myelocytic lines. There will be metas, mylos, pros, bands, and even some mature neutrophils. Not just neutrophil cells, we're going to see this across the board in eosinophils, basophils. We are going to look for some chromosomal abnormalities. And in the case of CML, there will be a Philadelphia chromosome, BCR, ABL gene rearrangement, and translocation at 922. Now, CML has 3 different stages because, again, remember, these conditions can transition from chronic to acute, and CML is a little bit special too because it also falls under the myeloproliferative category, which we're going to talk about here in just a bit. Treatment for CML is going to be chemotherapy, leukapheresis, supportive therapy, and bone marrow transplant. And then the 3 stages that we have are going to be chronic stage, accelerated stage, and the blast crisis. Now, if we are able to treat this patient in the chronic stage, we have a much higher chance of remission and a better prognosis. However, if it gets to the accelerated stage and then to blast crisis, the more advanced the disease state goes, the less favorable the prognosis and potential treatment outcome. All right, so that wraps up our leukemia flowchart. Again, if you have any questions, feel free to email me, text me, or ask me during class. Okay, we are moving right along. So our next flowchart, it deals with myeloid disorders. So our myeloid disorders come in two flavors. Neither one of them are particularly wonderful flavors, but let's talk about the first one. So myeloproliferative disorders are usually a proliferation of one or more cell line, usually has a predominant cell line of proliferation. Typically, these myeloproliferative disorders present with a hypercellular bone marrow um, and an increase in a variety of different um, cell lines depending on which type of myeloproliferative disorder we're looking at. There are typically there are at least a few cytogenetic anomalies that we see associated with different myeloproliferative disorders, but some of them overlap. So we really want to kind of um, pay attention to that. Now, there will be other testing we can do in myeloproliferative disorders to kind of confirm our findings or at least support our suspicions. And ultimately, we would have to go in and do a bone marrow and kind of do that cytogenetic testing if that applies. And this is also where CML overlaps into this category of myeloproliferative disorders. So again, CML can be categorized as a myeloproliferative disorder, or it can be classified as a chronic myelogenous leukemia. All right, the other side of the flowchart is going to be specific to myelodysplastic. And ultimately, myelodysplastic syndrome is also hypercellular, but with an increased apoptosis. And the reason for this is because there is something happening during development that goes awry. So it's not so much that we're making too many, it's that we're making too many and they're broken. So most of those cells go through apoptosis and die before ever going out into circulation. So we're going to see cytopenias. We're going to see megaloblastic features that are not B12 and folate associated. A couple of different things. So let's go back to myeloproliferation and talk about each of these cell lines and each of these disease states or conditions. Let's talk about first polycythemia vera. So polycythemia vera is a proliferation of red cell precursors, white, and megakaryocytes, but there's a predominance in the red blood cell precursors and in the Igs. So we're going to see a normal ME ratio, even though there's a proliferation. The reason why is because we're seeing an increase in both the immature grands and the reds, so they still maintain that ratio of about 3 to 1, 2.5 to 1. There's going to be an increase in megakaryocytes and a decrease in those iron stores. And of course, that's because red blood cells require a lot of iron in order to produce a lot of cells. And with this proliferation, with a predominance in red cells, we're utilizing up all the iron stores pretty fast. And that's going to be in the bone marrow. In the peripheral blood, we're going to have an increased white blood cell count. We might have left shift with immature granulocytes. We may have thrombocytosis. Some other lab tests that we're going to have are an increased red blood cell and hemoglobin and hematocrit, increased uric acid. Now, this is going to be associated with an increased LAP score. And then the telltale of a polycythemia vera with all of these little pieces of the puzzle, with the chemistry testing, the bone marrow findings, the lap score, all of those things are going to be pieces of the puzzle, but really we are going to have that JAK2 mutation to kind of put all the pieces together. Now, polycythemia vera is not the only condition, only myeloproliferative disorder that's associated with the JAK2 mutation, but it is the one that I always remember because it hijacks the need for erythropoietin. So that JAK2 mutation has hijacked erythropoiesis or hematopoiesis really in the absence of erythropoietin, and that is because of that mutation. The gene just comes on, stays on, and continuously um, prompts the bone marrow to make more and more red cells, and predominantly, but also some whites and megakaryocytes. Because of this overproliferation, we have a couple of different stages. Mostly this end stage is going to be called the spent phase, and that's when the bone marrow starts to fail, the patient becomes anemic, and sometimes this can transition into myelofibrosis. So we get a fibrotic bone marrow. Next, we have treatment, which is going to be chemotherapy and therapeutic phlebotomy. So we can pull out that excess blood volume, because remember, people who have polycythemia vera, shall I say primary polycythemia vera, often have hypovolemia. Nope, excuse me, hypervolemia, meaning too much blood volume, and that can lead to headaches, seizures, stroke. It can lead to a lot of issues, increased blood pressure, thrombosis. So we want to try to alleviate that pressure from the patient. The next one is essential thrombocythemia. That's going to be primarily associated with the platelet or the megakaryocytic line. What we'll see in the bone marrow are these sheets and sheets of platelets. We are going to see a ton of platelets in the peripheral blood. We might have an abnormal platelet aggregation with epinephrine, so that platelet aggregation study is going to be one of the things that we might do in the presence of epinephrine. And again, this can transform into an AML, a polycythemia vera, or a myelofibrosis. So again, these myeloproliferative disorders they're having identity crisis. They don't really know who they are yet. They're trying to discover themselves, which is fine, but unfortunately for the patients, sometimes they get multiple diagnoses over time. Again, these patients can have bleeding or clotting problems. So essential thrombocythemia is not fun. Let's see, myelofibrosis. This one's not cool. So our proliferative cell lines are going to be those megakaryocytes and fibroblasts. And that's why we start getting that fibrotic bone marrow. Our bone marrow is going to result in a dry tap, meaning that the biopsy clot will show fibrosis and we may not be able to get an aspirate at all. We've got some predominant cell morphology that's going to primarily be teardrops. We may have ovalocytes, nucleated red blood cells, Howell Jolly body, basophilic stippling, and kind of just weird platelets overall. And again, that has a lot to do with the fibrotic tissue in the bone marrow and also the proliferative process that is going kind of off. Next, we've got some other lab tests for under myelofibrosis, increased uric acid and LDH, so that lactose dehydrogenase. Myelofibrosis is typically a gradual onset, and it usually occurs when another myeloproliferative disorder has transitioned into myelofibrosis. Bone marrow transplant is the best way to treat it. But again, depending on your overall health and wellness, you may or may not be a candidate for that. Next is our CML. Again, we just talked about this, but we're going to have immature granulocytes in abundance. We are going to have hypercellular bone marrow with an increased ME ratio. Lots of immature grans and possibly a few blasts, but they're not going to exceed the line in the sand, so they will still be considered CML. We might have a decrease or absent LAP score. We are going to have a very elevated white blood cell count. And we're going to again have that cytogenetic chromosomal abnormality of the Philadelphia chromosome on BCR-ABL fusion, and then that translocation 922. Comes in 3 stages, the chronic, accelerated, and blast phase. And then, of course, make sure we take note of the percentage of blasts that are associated with each phase. And then we have, it can resemble a leukemoid reaction, and this is one of the reasons why we really utilize that LAP score. Okay, continuing on to our myelodysplastic side. Again, we're going to have peripheral blood cytopenias with ovalomacrocytes, Howell Jolly bodies, and basophilic stippling, along with nucleated red blood cells. We are going to have that hypercellular bone marrow with dyspoesis, and in order for it to be considered a myelodysplastic syndrome rather than a transition into an acute leukemia, we are going to make sure that we maintain less than 30% blast in the bone marrow. If you see greater than that, then we may be in transition. So in terms of our MDS, our CML, our FAB classifications are refractory anemia, and ultimately we're going to see about less than 5 to 10% of blasts in the bone marrow. We're going to see those megaloblastic precursors in bone marrow, but we're going to have a normal B12 and folate. Then we're going to have a refractory anemia with ring sideroblasts, so 15% or more ring sideroblasts in the bone marrow. Then we'll have refractory anemia with excess blasts, so 5 to 20% blast, cytopenia in at least 2 cell lines, but maybe more. And then when we hit that 20 to 30% blast in the bone marrow, we're looking at a refractory anemia with excess blast in transition. And this has a very, very high risk of becoming an acute leukemia. Myelodysplastic syndromes actually have a higher risk of transitioning into an acute leukemia. We've got our other 2 types of myelodysplastic syndromes, CMML, which is going to be monocytosis in addition to a CML presentation, so a chronic myelogenous monocytic leukemia. It's not very common, but it kind of is just the myelomonocytic cousin or sibling to CML. But then the myelocytic cells dominate in the bone marrow. And then MDS variants are going to be hypoplastic MDS, myelodysplastic syndrome with fibrosis, unclassifiable MDS, therapy-related MDS, and then that 5q deletion syndrome on that long arm of chromosome 5. All right, so moving on to our last flow chart in our white blood cell unit, we have our lymphocyte disorders. We're going to break that down into 3 categories. First, our reactive lymphocytosis, our lymphomas, and our plasma cell disorders. So let's first talk about our reactive lymphocytosis. What we're going to be looking at is an absolute lymphocytosis, which is the percentage of lymphocytes times the white blood cell count. And then our relative lymphocytosis is going to be associated with the increase above our normal range of lymphocytes, but it can be normal. So it really just depends on how many white blood cells you have and what proportion of those is above the normal limit or the normal range of lymphocytes. Infectious mononucleosis, it could be it's caused by the Epstein-Barr virus. We can utilize the monospot test, which is a lateral flow heterophile antibody test. Epstein-Barr virus by PCR is our confirmatory test, and what we expect to see on the scope underneath the in the peripheral blood is greater than 10% of atypical lymphs and greater than 4.5 absolute lymphocytosis. Characteristics and lab testing for cytomegalovirus, which is our next type of lymphocytosis. Usually CMV by PCR. We might also do immunoglobulin IgG and IgM. For the most part, cytomegalovirus is widespread. Most people have been exposed to it at some point in their life, and it's usually asymptomatic. However, in people who are immunosuppressed or immunocompromised, such as chemotherapy patients, the elderly, very small newborn babies, those people can definitely, it can be fatal for them. And then last but not least, other causes, pertussis, aka whooping cough. Now remember, most of the time lymphocytes are associated with viruses. Pertussis is a bacterial infection, but it is the exception to the rule. And then we might also have some leukemias, some lymphomas. It just really just depends on kind of what the disease state is, what the process is, why do we have this elevated lymphocyte count. And if you were to see a reactive lymphocytosis and you were not able to get to the answer utilizing of these other tests, you might go in and do a bone marrow biopsy, some flow cytometry to see what the cause of this lymphocytosis is. All right, moving on to our lymphomas. We are going to divide our lymphomas into two categories. We're going to divide it into Hodgkin's and non-Hodgkin's. Ultimately, our hallmark cell for a Hodgkin's lymphoma is a Reed-Sternberg cell, and of course that does come in variants, but the rule of thumb is Reed-Sternberg cell or one of its variants have to be present in order to categorize it as a Hodgkin's lymphoma. We do have a couple of different types in terms of their cellularity or their mix. We have lymphoma predomination or lymphocyte predominant, and it's kind of uncommon. We are going to have those lacunar and LNH cells or those popcorn cells, which the popcorn cells are one of the variant Reed-Sternberg cells. Next, we have mixed cellularity, and it's pretty uncommon. We're going to see lymphocytes, histiocytes, plasma cells, Reed-Sternberg, so kind of a mixed type of cell population. And remember, a lot of these are happening in the lymphoid tissue, so the lymph nodes, maybe the bone marrow. Usually Reed-Sternberg cells and Hodgkin's lymphoma are more associated with lymph nodes, or at least that's where they start, and then they may disseminate. But third type is lymphocytic depletion, so we're going to see a domination in Reed-Sternberg cell and bone marrow involvement at this time. So in this case, we would have bone marrow involvement, where other types of Hodgkin's lymphoma in the early stages are not necessarily going to have bone marrow, even though bone marrow is technically considered a lymphoid tissue or organ. And then last but not least is the nodular sclerosing. This is the most common, and it is predominantly found in females. So be familiar with your Ann Arbor staging. We have stage 1 of Ann Arbor 8 staging for Hodgkin's lymphoma, and that's going to be a 1 node in or organ. 2 is going to be 2 nodes on the same side of the diaphragm. 3 nodes on both sides of the diaphragm. And 4 is disseminated into lymphatic organs, in multiple lymphatic organs. All right, now moving on to our non-Hodgkin's, we are going to be looking at a predominantly B cell population of lymphocytes. And then we break it down into follicular versus diffuse. So this is really referring to the area of the lymph nodes that are more extensively infiltrated. So follicular, we're going to see is kind of rare in children. It is a B cell population, and these patients have a better prognosis. And then in terms of the diffuse, that can be B or T cells. It's usually more aggressive and a higher grade. Moving on, we have non-Hodgkin's Burkitt's lymphoma, which is also population of B cells. It has a starry night appearance in the bone marrow and can be caused, there is, how shall we say it, there is a relatively high correlation of people who have had Epstein-Barr's and then later on develop Burkitt's lymphoma. So there is an association. And then last but not least, our cell population in the mycosis fungoides or Sézary syndrome that typically begin in the elderly skin and then advance to the lymph nodes. So in that case, it starts in the skin. Our last lymphocyte disorder is our plasma cell disorders with the big old biggie MM, my initials. I do not claim MM though. So multiple myeloma is going to be an overproduction of those plasma cells. Peripheral blood findings are going to include rouleau, circulating plasma cells, although there won't be in high numbers in circulation. We might have an elevated SED rate and CRP. We will have an elevated serum calcium level, BUN, and creatinine. And then if we do electrophoresis, protein electrophoresis, we are going to see an M spike in that gamma region of our gel. We may find Bench-Jones proteins in the urine. We're going to do that immunofixation electrophoresis for that monoclonal gammopathy. And then we're going to kind of look to see what class of immunoglobulins are present, and specifically our free light chain. Are they lambda? Are they kappa? How many do we have? Like, what's, kind of, that's going to kind of lead the doctor to formulate a plan of treatment and then evaluate the prognosis. Unfortunately for people in multiple myeloma, they have a kind of a poor prognosis simply because, again, infection gets them before treatment can save them, and that's because of the inability of the body to make functional antibodies. So remember, antibodies are one of our protectors. And when the only type of antibodies we're making are just an excess of free light chains, they don't have their heavy chains, they don't have their receptors, they are pretty much useless, so then we aren't producing enough functional immunoglobulin to help us protect our bodies from infection. And then again, just remember, Babs the crab, calcium's increased, rouleau and renal problems, anemia, bone lesions, and back pain. A couple of other plasma cell disorders that we have is MGUS, which is going to have a small M spike in the gamma region, but no other multiple myeloma findings. Although a lot of these patients who have MGUS tend to develop multiple myeloma. A certain percentage of them do develop multiple myeloma down the road. And then last but not least, Waldenstrom's macroglobulinemia. This is going to be an overproduction of that monoclonal IgM. This is going to cause a hyperviscosity syndrome, neurological problems, heart problems, bleeding, cryoglobulinemia. So we're going to have cryoglobulins in the blood. And ultimately, we really have to manage this. Sometimes we do it by plasma electrophoresis to pull out those excess immunoglobulins that are causing hyperviscosity. So there are a couple of different treatments we can do, but ultimately, this is an overall picture of things that can go wrong with our lymphocytes. So hopefully none of you ever experience any of these firsthand. However, it's really important to know about them so that we can recognize them when we see them on patient samples. Okay, so let's talk a little bit about case study evaluation and where to start. There are a couple of things that might be helpful when going through the thought process of case study evaluation. First and foremost, you're really going to want to read that patient's history, their signs and symptoms, because that is ultimately going to give you some clues about what you may be looking at. Next, we're going to look at the lab results. And the first thing we're going to ask ourselves are these labs abnormal? Are any of the labs abnormal? And if so, which of those labs are abnormal? Once we determine whether or not the labs are normal versus abnormal, we're going to ask ourselves, can these abnormal labs help ID the disease state? So there are a lot of things that, for example, if you have a CBC and you have anemia, so you have a low hemoglobin, that could point in a lot of directions. So sometimes we might have kind of like an idea based on the patient's signs and symptoms, maybe a history, but if you aren't able to look at the labs that have already been performed, ask yourself about additional testing. Which labs could I run in addition to the ones that have already been run to give me more information? What is the outcome of the additional testing? So does this give me, like, what information do I have and which direction can I go? What conditions do I know that could present this way? So now we're going to narrow it down and classify the disease state based on the information, the signs and symptoms, patient history, demographic, and the labs and tests that we've done. So when we narrow it down or classify to the disease state, we're going to take all of the information that's been presented to us through our laboratory results, patient history, signs and symptoms, and maybe even some radiology exams that could be part of our case study. We ask ourselves, what condition is it most likely based on um, lab results, signs and symptoms, and patient history? And once I get to a condition, can I narrow it down further to a class of conditions within that realm? And then we're going to look for things that are uniquely specific to the condition. Are there cytogenetic markers or tests that are specific? Are there morphology hallmark cells that are consistent with a finding? So take all of those things into consideration when narrowing it down so that you can classify it. Now, you've gone all the way through classifying it to a specific class of disease state, and you're like, okay, this is my suspicion based on A, B, and C, or in this case, 1, 2, and 3. Let's confirm our findings, and then we can determine the treatment and the prognosis. So what tests would confirm or rule out my suspicions? So what confirmatory tests do we have? What type of treatment, if any, would be effective for this condition? And what is the prognosis for this patient? So you see how you start with the very basic and then you start to fill in the gaps piece by piece by utilizing all of the information at hand. So let's go ahead and do the first case study. I have posted the answers. I'm not going to go through all of them with you today, but I will come back and do those case studies with the audio tomorrow. I want to get them done before your exam, but today I'm running short on time, and so I will just leave it at this point and then I'll come back and add to it. Welcome back. So let's go over our white blood cell case studies together. We're going to work through kind of the thought process, the troubleshooting on how to work our way through these case studies. And I do notice a typo on my slide. My apologies, but this is 11 case studies to put your brain to work, not to sharpen, to put your brain to work. So my apologies for the typo. Okay, let's start out with case study number 1. A 45-year-old diabetic female saw her doctor because of painful and difficult urination. So the first thing we want to do is look at the lab results that we have. So we have a white blood cell count of 28.52, neutrophil count of 79%, lymphs at 10%, monos at 9%, and eos at 2%. Most of the neutrophils displayed dark, coarse granulation and vacuoles. The patient's urine had an elevated amount of protein, large number of white blood cells and bacteria, and the urine culture was positive for a gram-negative broad Pseudomonas species. Okay, so let's take all of that information and kind of think it through. So patient's diabetic, painful and difficult urination, and what do you notice about these lab results? Do you see anything abnormal? That's the first thing we're going to look at. And in this case, yes, she does have an elevated white blood cell count. And the information given to us is also that she has a bacterial infiltration in her urinalysis. So that would lead us to kind of think about what could be going on with this patient. So let's kind of move forward. On the peripheral smear, we noted that the neutrophils displayed dark, coarse granulation and vacuoles. What is the dark, coarse granulation in the neutrophils? Well, if you suspect a bacterial infection of sorts, the most likely cause of the dark, coarse granulation in the neutrophils would be toxic granulation. Because remember, we have a few things that are associated with infection. One of them is toxic granulation, one of them is Dolly bodies, and the other we see vacuolated neutrophils. So, does this condition, meaning the granulation, alter the phagocytic effectiveness of the neutrophils? No, it does not. So it's not going to impair the ability of the neutrophil to do its job. And then, of course, what is the most probable explanation of this patient's elevated white blood cell count? Well, we know that when our body has an infection and our urine culture was positive for a bacterial species, we know that our white blood cell count, it becomes elevated to enhance the defeat of the bacterial infection. So all of those pieces put together would indicate that this patient probably and most likely does have a UTI. She does have a UTI because we are seeing empirical evidence with her urine culture that she is positive for gram-negative Pseudomonas species. All right, white blood cell case study number 2. This one can be a little tricky, so you're really going to have to think through this one carefully. The only patient history and information that we have is that we have a 31-year-old male who was admitted to the burn unit. Now let's stop and digest that for a minute, because in one small sentence that tells us a lot. We know that this patient's burns must be significant, because if you were to just get a small burn, obviously they would not admit you to the burn unit. So people who are admitted to the burn unit typically have very significant amounts of burn. And so that tells us that his skin barrier has been significantly compromised. So that kind of gives us quite a bit of information, even in that little bit of patient history that we have. Let's look at our lab results. So we have CBC results here. We have our white blood cell is 15.86. Our red blood cell is 6.05. Hemoglobin is 18.3. Hematocrit is 54. MCV is 89, MCH is 30, MCHC is 34, RDW is 12.5. We have a platelet count of 450. And then in terms of our differential, we have 76% neutrophils, 18% lymphocytes, and 6% monocytes. Upon observing the peripheral blood smear, we have noted light blue gray inclusions within the cytoplasm of the neutrophils. Okay, so now we have our lab results. The next thing you're going to ask yourself is, are any of these results abnormal? Are they outside of the normal range? And the answer to that is yes. So our white blood cell count is a little elevated. And what could cause an elevated white blood cell count? Well, there are a lot of things that could cause that. Infection, inflammation, stress due to trauma. So any one of those things could be um, apparent or could be a result of the burn. What about the red blood cells? We have an elevated red blood cell of 6.05. We have an elevated hemoglobin of 18.3 and a hematocrit of 54. Those are also all elevated. So let's stop for a minute and think what could cause our red blood cell, hemoglobin, and hematocrit to all be elevated? Well, we know of a couple of things that can cause that. Our platelets are also elevated. So when we think about the sort of things that we've studied or things that can cause an elevation in all of white blood cells, red blood cells, and platelets, you might be thinking, okay, maybe this guy has a proliferative red blood cell disorder like polycythemia vera. Well, if this patient had polycythemia vera, we would see a much greater increase in the red blood cells, the platelets, and the white blood cell. Because remember, polycythemia vera is predominantly red blood cell proliferation, but it does also cause elevated white blood cell and platelets. So these white blood cell and platelets are only slightly elevated. They're not so significant that you would think of a proliferative disorder. This is more of a physiological response to the burns. But what about the red cells? So we could be looking at something like a secondary polycythemia, and this is acquired due to a decrease in the fluid portion of the blood. So if you really think about what red blood cell, hematocrit, and hemoglobin kind of represent, we're looking at percentage of cell matter in comparison to the percentage of the fluid portion of our blood or that plasma. And when we lose a significant protective barrier like skin, when a patient goes through significant burns like that, they are unable to protect themselves from fluid loss the way that they normally would when that skin had its full integrity. So what happens with burn patients very often is they become very dehydrated because they're losing not only all of that fluid, that interstitial fluid is kind of seeping out, but when they take fluids in, it just evaporates or leaks out of those burns because of that protective barrier has been compromised. So this patient would have a secondary polycythemia due to dehydration because of those severe burns. Now, what about the blue-gray inclusions in the cytoplasm of the neutrophil? We see these all the time in burn victims, and those would be indicative of Dolly bodies. Now, we can see Dolly bodies in infectious responses, trauma responses. So this patient has both trauma response and is probably trying very hard, his body's trying very hard to prevent any infection because, again, he's lost the integrity of that skin barrier, which also helps protect against bacterial infections. So Dolly bodies would be the most likely answer for number 2. And then number 3, is this abnormality diagnostically statistic? Well, no, because it's not specific. When we have something that's kind of a vague observation like Dolly bodies, we can't specifically say, oh, I see Dolly bodies, this patient has a burn. Although we do see Dolly bodies fairly consistently in burn patients, it's really just an indicator of increased stress on the bone marrow. The bone marrow is trying to compensate. Everything is now out of balance. Fluid balance is out. Now we have exposed tissue that used to be protected. So it's really just an indicator, but it's not specific to just this diagnosis because we can see Dolly bodies in a lot of different situations. Okay, Case study number 3, we have a little bit more information. We have a more extensive panel of test results that we can look at to kind of point us in the right direction. A 38-year-old white female had been complaining of fatigue and had been experiencing night sweats for several weeks. She also reported that she was bruising easily lately and appeared pale. The physical examination revealed pale mucous membranes and hepatomegaly, but no lymphadenopathy. So she's not feeling too well, it seems. Let's go ahead and look at her CBC diff results and see if that can give us any clues. Her white blood cell count is 110.01, red blood cell is 2.53, hemoglobin is 7.4, hematocrit is 22, MCV 87, MCH 29, MCHC 34, RDW is going to be 16.2, and her platelets are 48. With regard to her differential, we look at the slide and we see about 53% blasts with many hour rods, 12 promyelocytes, 8 myelocytes, 8 metamyelocytes, 14 neutrophils, and 7 lymphs. So with that information alone, we have a lot going on. So let's look to see, are there any abnormal labs? Well, first and foremost, her white blood cell count is very abnormal. It is super elevated. Red blood cell counts are looking kind of, you know, not too great, but it could be worse. Hemoglobin 7.4, so that's low. And her hematocrit is low. So this patient is anemic, which could explain why she has that pale appearance and pale mucous membranes. Her platelets, though, those are ridiculously low, 48. That could explain why she has easy bruising lately. So she's just not, her platelet count is super low. Her differential is going to give us a lot of information as well. So we're seeing 53% blasts. Now, I want you to stop for a minute and think about our immature percentages. We talked about this during our leukemia unit, and we know that there's a sand in the line where we draw between acute leukemias and chronic leukemias. And if you recall, that magic number is equal to or greater than 30%. So even though this is peripheral blood, it's a reflection of what's going on in the bone marrow. If we have 53% of our white cells circulating as blasts, we know that this patient has an acute leukemia of some kind, okay? And those blasts have hour rods. Now, if you think back, ask yourself, what are hour rods made out of? They are fused primary granules. Okay, so next we're going to ask ourselves, okay, what cell lineage does that point us to? Is it going to be a lymphocytic lineage or is it going to be a myelocytic lineage? And the answer to that is myelocytic lineage because of those hour rods. Lymphocytic lineage do not have granules. They don't have primary granules that could be fused to form those hour rods. We also have promyelocytes, myelocytes, metamyelocytes, and so the majority of the immature cells that we're seeing are all of a myelocytic lineage. So this patient now we can say has an AML, and now it's kind of like, let's figure out what kind of AML this patient has. What classification of AML does this patient have? Because remember, we have several classifications, M0 through M7. So let's now move forward with some cytochemical stains. A follow-up cytochemical stain showed that the blasts were positive for Sudan black B, with a variable number of moderate and coarse black granules. Okay, so that's what we would see in a positive Sudan black. We would see those black granules present in the cells. A periodic Schiff PAS stain was negative. Okay, so that tells us that we're dealing solely with maybe a granulocyte group. We're not going to be looking at monocytes and monocytic involvement in this. So this is going to be granulocytic. The bone marrow aspirate proved to be hypercellular. So we know that with many of our leukemias, they have a hypercellular bone marrow. And of course, the predominance of granulocytic precursors. So again, this is also pointing us in the direction of granulocytic cell populations. Now, the biggest clue that we're going to be able to get, because it is pretty specific to a specific AML, is cytogenetic studies. And this has demonstrated a translocation at 821. In addition to that, there's an alteration, the 821 alteration and the loss of a sex chromosome. So this patient has more than one cytogenetic abnormality. So based on our cytochemical stain patterns, our indication of a granulocytic population with those hour rods that are present, the percentage of blasts, and the cytogenetic studies, we can most definitely say that this is an AML M2, also called the myeloblastic with maturation. So the reason we know it's myeloblastic with maturation is because we see a variety of phases of maturation happening. So we've got blasts, which are the least mature. Promyelocytes, myelocytes, and metamyelocytes are all various phases of development. So that shows that there is a maturation process happening, even though they're immature. They're not all blasts. Again, what might we do to confirm the diagnosis? So we have a strong suspicion it's AML M2, but we have to prove it. We have to be able to provide testing to definitively support our initial suspicion or diagnosis. So we could do further cytochemical stains. So we could do that specific and non-specific esterases just to prove that only granulocytes are the making up the majority of that cell population. And we are definitely going to want to do that flow cytometry. Flow cytometry is going to narrow it down so specifically to the cell markers that are present on those malignant white blood cells. All right, so what is the prognosis? So if you think back to our leukemia unit, unfortunately, the more cytogenetic abnormalities that a patient has, the poorer the prognosis. And in this case, the patient has a translocation and a loss of that sex chromosome. So this patient has a pretty poor prognosis overall. Obviously, they are, hopefully going to get some treatment. But in this case, we don't really have much discussion about treatment, but obviously they would do probably some chemotherapy, maybe some radiation, perhaps bone marrow transplant. It really just depends on the patient's overall wellness. Some patients do really well with those treatments. Other patients just can't tolerate it well due to maybe other comorbidities. This patient's pretty young in terms of age, 38, but again, due to those multiple cytogenetic abnormalities, prognosis probably isn't too great for this patient. Okay, case study number 4. A 32-year-old female had been referred to her family physician after seeing her dentist for swollen and bleeding gums. Okay. Physical examination revealed that the patient was pale and febrile, so she had a fever, and had hepatosplenomegaly and lymphadenopathy. So this patient has enlarged liver, spleen, and swollen lymph nodes. Let's take a look at her CBC results. So in this case, we have white blood cell count of 32.07, red blood cell of 3.5, hemoglobin of 10.5, hematocrit of 32, MCV 90, MCH 30, MCHC 33, RDW 15.2, platelet 12, and her differential is showing 89% blasts, 6 promonocytes, 4 monocytes, and 1 lymphocyte. So next question, are any of these labs abnormal? So yes, her white blood cell count is elevated. She's a little bit anemic because of that lower hemoglobin, but her platelets are really unhappy. She's got a lot of blasts, so that's going to tell us that we're looking at an acute leukemia, and she has monocytic populations along with those blasts. Now, if we were to look at those blasts, we can't definitively say that they are from a monocytic line, but because of the other immature cells that we're seeing, we might suspect there's some monocytic involvement. The other thing that kind of indicates that is the patient. She has some signs and symptoms that could lead us to believe that there is some type of a monocytic proliferation. And that's because she's got those swollen and bleeding gums. Now, along with that, she has hepatosplenomegaly and lymphadenopathy. If we think about the job that monocytes do, they go into our circulation, so peripheral blood they're circulating for a very short period of time, and then they migrate into the tissues to perform whatever duties it is that they are. So they might be resident macrophages in the mucous membranes. It might be in the bone marrow doing as siderocytes. They might be, antigen presenting cells there on the reticular endothelium. All of those things are important. They might go to be splenic macrophages, resident splenic macrophages to help with red blood cell cleanup. All of those things are going to be jobs that a monocyte would do. Now, if you have an overproliferation of monocytes, they're still going to do the job they're programmed to do, but now there are just too many of them, and that can lead to things like swollen and bleeding gums. All right, let's look at the bone marrow aspiration. And indeed, we find predominance of immature and abnormal monocytes. There was no increase in granulocytic precursors. So we're looking at the majority of cell population in the monocytic line. Cytochemical tests were as follows. Sudan black B, slightly positive, and we know that Sudan black B does weakly stain monocytes. The NASD was negative, and we know that it would be negative if there's an absence of granulocytes, because remember that specific esterase is very specific to granulocytes. If that's negative, that tells us there's an absence of granulocytes there. And then the butyrate esterase, which is the non-specific esterase, stains positively with monocytes and a couple of other cells, but it's going to give us a good indication based on the whole picture. Cytogenetic studies revealed a translocation at 9 and 11. So if we take all of that information, what is the diagnosis? Well, I would highly suspect an AML M5 monocytic acute leukemia. So let's kind of talk about some of the morphological features that the blasts may show. Now, I know in the past I have said a blast is a blast is a blast, and we can't really tell what lineage it is just by looking at the blast. But in some cases with monocytes, we do see a convoluted nucleus and very apparent nucleoli. So those little areas of clearing within the nuclear chromatin, and that's very characteristic of monoblasts. Unfortunately, these patients are also very susceptible to other clinical symptoms because of this type of leukemia, and there are a couple of them. But one of the big concerns about AML M5 is the higher risk of disseminated intravascular coagulation, which is a consumptive coagulopathy. So we're going to talk more about DIC in in our coagulation unit, but just be aware there are a couple of these acute myelocytic leukemias that have a higher incidence of DIC, and M5 is one of them. So familiarize yourself with with each one of those classifications of AML, and take note of which classifications are associated with secondary clinical symptoms or clinical presentation of other kind of complications like DIC. Because although M5 has a higher incidence of DIC, there is another one, so take note of which others might be associated with DIC. Okay, case study number 5. So sometimes patients come in with kind of vague generalized signs and symptoms. So it could be a multitude of things. In this case, a 60-year-old male saw his physician because of severe abdominal pain and back pain and nausea. So the doctor ran a CBC, and let's see what he found, he or she. White blood cells 185.36, red blood cell 4.12, hemoglobin 12.5, hematocrit 36, MCV 87, MCH 30, MCHC 35, RDW 14.5, platelet 120. So other than that really elevated white blood cell count, everything else is pretty normalish looking. Platelets are a little on the low side, but not horrible. Let's look at the differential, however. So this patient has 45% blasts, 4% promyelocytes, 10% myelocytes, 3% metamyelocytes, 8% neutrophils, 13% monocytes, 10% promonocytes, 7% lymphocytes, and then when they performed a urinalysis, they found there to be 100 milligrams per deciliter of urine protein, which protein should not be in the urine, so something's going on. The more concerning thing to me, though, is that cell population. So, yes, they have a very elevated white blood cell count. Red blood cells, for the most part, look pretty normal. But that tells me there's some type of a proliferation of white cells for some reason. And when we look at the percentage of blasts, it has crossed that line over 30%, so we know that this is going to be an acute leukemia. Based on these results, what is the probable diagnosis? So we know it's an acute leukemia. We know that there are myelocytic cell lines involved and monocytic cell lines involved. So our best guess at this point, even though we don't have we don't have any cytochemical stains, but based on the cell populations, AML M4 myelomonocytic would be my best guess. And now we might need to do additional testing, right? So what additional tests could be needed to establish a diagnosis? Well, let's look at our cytochemical stains, because that's really going to make, kind of solidify what our findings are. So we might do a Sudan black B cytochemical stain and a myeloperoxidase cytochemical stain. We might also do specific and non-specific esterases to see are there indeed myelocytic and monocytic involvement. And then, of course, we would do a bone marrow biopsy, aspirate, and a flow cytometry to kind of get a better view of what's going on within the bone marrow, and then be able to identify those cells based on their we would want to do a bone marrow and flow cytometry on that to identify those cellular markers. So what is the prognosis? Okay, so with this condition, this patient has an increased chance of survival with chemotherapy and bone marrow transplant. So it's really hard to say what the prognosis is really. I mean, with treatment, yes, there's an increased chance of survival. But this patient's a little bit on the older side and may not tolerate it well, especially if he has other comorbidities. Seeing that there is urine in his protein tells me this patient might have some renal insufficiency. I don't really know much of the patient history because we didn't get that, but if this patient has um, renal insufficiency, maybe diabetes, other comorbidities, that's going to make the prognosis a little bit less favorable for a patient who is 60 years old. Also, we know that people in their older years do not tolerate the process for bone marrow transplant very well. But in general, hopefully with this treatment, hopefully the patient will be able to tolerate it. There is an increased chance of survival. Age is going to make a bit of a difference, though. Again, younger people have more success with that bone marrow transplant process. Okay, we're almost halfway through these case studies. I hope these are starting to make more sense as you work through the thought process of solving these case studies. Case study number 6. We have a 3-year-old black female who was taken to the pediatrician because of an uncontrollable fever. The mother also reported that her daughter had been crying, pulling at her ear, and complaining from a sore throat for the last week. The physical examination revealed an inflamed tympanic membrane, lymphadenopathy, and hepatosplenomegaly. Okay, so looks like she might have an ear infection. That would be the first thing I would think with a 3-year-old. But, and even with the lymphadenopathy, you might think, oh, she's got an ear infection. Her lymph nodes are a little bit swollen. But that hepatosplenomegaly is a bit more concerning to me. So an ear infection wouldn't cause hepatosplenomegaly. So let's take a look at white blood cells, 66.75, which is elevated, red blood cell 2.67, hemoglobin 8.2, hematocrit 25, so this baby is anemic. MCV is 94, MCH is 31, MCHC 33, RDW 15.0, and this poor baby has 21 platelets. Looking at the differential, we now have 76% blasts, 12% prolymphocytes, and then 12 lymphocytes as well. So our question is, what's causing the anemia? What's causing the elevated white blood cell count? And what's causing that platelet count to be so low? Looking at these results, we know this patient crosses that line in the sand and is greater than 30% blast. So this again is going to be some type of an acute leukemia. We're then going to investigate our lineage. So it looks like we've got lymphocytic lineage present or apparent in the peripheral blood smear. Let's take a look at the rest of our testing and see what else we found. So in the peripheral blood smear, the blasts were round and had 1 to 2 nucleoli with a high nuclear to cytoplasmic ratio. Okay, so sounds like a lot of other blasts. Our rods were not present, so no indication of fused primary granules. The cytochemical staining pattern of the blast were as follows. So PAS was strongly positive. Sudan Black B was negative, NASD was negative, and butyrate esterase was negative. So the only thing that it tested positive for was that PAS. So all of those negative cytochemical stains indicate to us that this is not of a granulocytic lineage. So it's more likely a lymphocytic lineage based on our differential, but also on our cytochemical stains. We might also want to do a TDT because we know that that would stain positive in lymphocytes. What is the most probable diagnosis? So I'm thinking, based on all the information we have, that the most likely diagnosis is acute lymphocytic leukemia, ALL. And again, this is the most common type of leukemia that we see in young children. So ALL tends to be associated with a pediatric population, although again, anyone can get ALL. It's just more predominant in pediatrics. What additional testing could we do to confirm our suspicions? We would definitely want to do a bone marrow aspirate. We want to see what's happening in the bone marrow and then perform flow cytometry. So, what about the prognosis of this child? Well, obviously, children are more resilient. They tend to have fewer comorbidities. The remission rate is very good in children with that treatment. So it might be chemotherapy, radiation, bone marrow transplant. But for the most part, there's a much better rate of remission in children with ALL than adults with ALL. All right, so let's take a look at case study number 7. A 64-year-old male saw his physician for persistent pain in his shoulder and wrist. The patient appeared pale but otherwise healthy. Okay, so that's kind of vague information, doesn't tell us a whole lot. But if he's pale, we might be thinking, okay, could there be some type of anemia happening? Let's see what his CBC results give us. So our white blood cell count is going to be 68.92. Red blood cell count is 3.85. Hemoglobin is 11.8. Hematocrit is 35. So the patient is a little bit anemic. MCV 91, MCH 31, MCHC 34, RDW 14.5, and platelet is 490. So that's a little bit high for a platelet count. So it's going in the other direction. Okay, let's look at his differential now. So we do have kind of a variety of immature granulocytes present. We have promyelocyte 1, myelocyte 8, metamyelocyte 15, 35% bands, 25% neutrophils, 14% lymphocytes, and 2% monocytes. He also has some nucleated red blood cells, so 5 out of 100. This is kind of, the point where you're like, is this a proliferative disorder or is this a physiological response to maybe infection or inflammation? Because white blood cell count is high, but it's not so high that, it's not like 110, like one of the patients that we previously saw. We do see some hemoglobin hematocrit abnormalities, so he's looking a little bit anemic, but not terribly so. And as we get older, our bone marrow isn't quite as efficient. So he is 64, but I'm really like torn, Could this be an increase in white blood cell count because of infection? Maybe he's got some type of infection in his joints, or are we looking at a proliferative disorder? So one of the things that we can do if we are looking at, trying to decide between a leukemoid reaction or that physiological response to an increased white cell due to infection or inflammation, or looking at a myeloproliferative disorder, we might do a lap score. We would use that lap stain, that leukocyte alkaline phosphatase stain, and we would then evaluate it. The other thing that we're looking at is this patient has an elevated platelet count. So that's going to kind of make me think, we might be looking at a myeloproliferative disorder, but not quite sure yet. Let's look a little further. So a subsequent bone marrow examination revealed a hypercellular marrow with increases in both granulocytic and megakaryocytic lines. Okay. So we have hypercellular bone marrow. If this was a leukemoid reaction, we probably wouldn't have hypercellular bone marrow. We might see an increase in granulocytic precursors just because there is an increased production based on need, but that wouldn't really necessarily give us an increase in the megakaryocytic line. So our most probable diagnosis, oh, wait, I forgot to give you the lap score. Sorry about that. So our lap score is going to be 5. So the most probable diagnosis based on all of the information that we have would be CML, chronic myelogenous leukemia. Now remember, CML falls under a couple of different categories. It falls under our chronic leukemia category, but it also falls under our myeloproliferative disorders. So if we're looking at a LAP score and it is 20 to 100, that would be normal. And this is low. Sometimes when we do the LAP score, it might even be absent. Because remember, that CML is resistant to that leukocyte alkaline phosphatase, whereas a leukemoid reaction would have a positive stain or would stain and be more apparent. You'd have a high LAP score, normal to high LAP score with a leukemoid reaction, and a low to absent LAP score with a CML. What other tests could we do to confirm the diagnosis? Obviously, we're going to do some cytogenetic testing. And remember that if we suspect CML, we're going to be looking for that Philadelphia chromosome with that translocation of 922. So that explains the elevated white blood cell count, but what about the platelet count? Well, because we have an increase in both granulocytic and megakaryocytic lines within the bone marrow, we're also going to have a higher platelet count because remember, those platelets are coming from that megakaryocyte population. How should this disorder be treated and what is the prognosis? Well, CML, because it's a slowly progressing chronic disorder, is highly treatable if we treat it in the chronic phase. Remember the 3 phases of CML: chronic, accelerated, and then blast crisis. We really want to catch it early, treat it specifically in the chronic phase. As it progresses, it becomes more refractory to treatment. But if we're able to treat it with that chemo, remember that Gleevec, and maybe a bone marrow transplant, the prognosis for this patient is pretty good. But again, his age is going to come into play, tolerance to treatment is going to come into play, and it looks like right now it's in the chronic phase. He's not symptomatic due to his leukemia. He's just old and has shoulder and wrist pain right now. So looks like they caught it in the chronic phase. So I think overall his prognosis is pretty favorable, depending upon how many other comorbidities he has and how well he tolerates the treatment. All right, moving on to case study number 8. A 55-year-old male was admitted to the ER with severe abdominal pain and diarrhea. The physical examination revealed extensive abdominal distension, fresh blood in the stool, increased temperature, decreased blood pressure, and rapid pulse. These are the CBC results. We have a white blood cell count of 63.56, red blood cell count of 4.50, hematocrit of 13.8, hemoglobin of 13.8, hematocrit of 42, MCV of 90 is 93, MCH 31, MCHC is 33, RDW 13.5, platelets a little elevated at 410. We have 2 blasts, 2 promyelocytes, 13 myelocytes, 20 metamyelocytes, 20 bands, 35 neutrophils, 4 lymphocytes, and 1 monocyte. So again, we're seeing some immaturity. We even see a couple of blasts in circulation, but this is going to be below that 30%, so it's not an acute. We do also see a little bit more maturity in the cells. So we have 20% bands, and usually anything greater than 15% bands is going to kind of put us into thinking about maybe a left shift. But it's really hard to tell without further testing. This looks like it could be early stages of a CML, or it could be a leukemoid reaction based on infection. So let's get a little further into it. The patient's temperature remained elevated and blood pressure was unstable throughout the night. A CBC the next morning revealed that the white blood cell had increased to 118.27. So that's a pretty big leap. 63.56 to 118 in under 24 hours. Later that day, the patient expired and an autopsy revealed mesenteric thrombosis and acute peritonitis. So based on the blood smear, we could be looking at a CML or a leukemoid reaction. We are a couple of things that we're going to use to kind of separate those two would be, obviously there's a huge jump from 63 to 118 in the white blood cell. That typically doesn't happen in a CML because remember that's a slowly progressing chronic condition, and we might see that in a leukemoid reaction. Um, we would have to do other types of differential testing. So we might do a lap score. And in this case, if the lap score was elevated, we'd know for sure that we were looking at a leukemoid reaction. We might do cytogenetics just to check to see if there's a presence of that Philadelphia chromosome and that BCR ABL gene rearrangement. So definitely, I'm going to lean toward the leukemoid reaction since our autopsy indicated that there was an acute peritonitis, which would be an infection of the peritoneal cavity. Usually that's caused from some type of perforation of the bowel, and all of those normal natural floras kind of leak into the peritoneal cavity and then lead to an infection. So again, we would definitely want to differentiate between a CML and a leukemoid reaction. It looks like this one was consistent with a leukemoid reaction. Okay, so moving on to case study number 9. A 59-year-old female was admitted to the hospital for minor elective surgery. The patient reported feeling fatigued lately, but believed that it was work-related. The physical examination revealed both a cervical and supraclavicle lymphadenopathy. So she has a few swollen lymph nodes in her neck and kind of under her clavicle there, or just above it. Her white blood cell count is 26.56. Red blood cell count is 4.2. Hemoglobin is 13.2. Hematocrit is 37. MCV is 88. MCH is 31. MCHC is 36. RDW is 13.2. Platelet is 250. Neutrophil 24%. Lymphocyte 75%. And monocyte is 1. So let's look here. What do you notice about the differential in this? Those lymphocytes are high in comparison to what a normal lymphocytic range would be. The neutrophils are low. The white blood cell count is elevated overall. And that would give us not only a leukocytosis, but a concurrent lymphocytosis. Some of the variant lymphocytes and smudge cells were present on the peripheral smear. An infectious mononucleosis screen proved to be negative, and the bone marrow examination revealed a lymphocytic proliferation. So this is looking like a lymphoproliferative disorder. Let's see. I don't see any blasts on this. Looks like red blood cells normal, hemoglobin's normal, hematocrit is normal. Everything looks normal. Platelets look normal. The only thing that I'm really noticing is just that elevation in lymphocyte percentage and the elevated white blood cell. So what could be the possible explanation for the leukocytosis and concurrent lymphocytosis? Well, considering that we aren't seeing any immaturity, any signs of immaturity, I would lean toward a chronic state. And since we know the involvement is primarily lymphocytic cells, I would consider CLL as a probable cause, along with the fact that we're seeing those variant lymphocytes, so those soccer ball lymphocytes and smudge cells present on the peripheral smear. We obviously want to do some additional testing to confirm our suspicions, and that testing would be flow cytometry. They're going to look at those cell markers present on those variant lymphs. And then for the most part, this patient's prognosis would be good. They for the most part, would have a slow progression. We would give supportive care as needed in the early stages, and then if the patient were to become symptomatic later on, they could be treated with chemotherapy just to knock that proliferative cell population down. Okay, we are getting to the end of the game. This is case study number 10. A 58-year-old male saw his physician because of increasing fatigue. He reported pain in his lower back and arms when he walked. The physical examination revealed pale mucous membranes and hepatosplenomegaly. Lab tests revealed that the patient was anemic, and it was noted on the differential report that the red blood cells were arranged in a rouleau or rolled coin pattern. The sed rate was increased at 55 millimeters per hour, and the urinalysis was normal. A skeletal survey indicated that the patient had bone lesions in various sites. Okay, so my mind is turning, and I'm kind of thinking, what do I see here that is specific to maybe one type of condition or disease? Well, one of the things I do know about rouleau is that it can often be associated with multiple myeloma. But if you remember, multiple myeloma is a plasma cell proliferation, and those plasma cells essentially just produce a bunch of dysfunctional immunoglobulins. And of course, those immunoglobulins, those free light chains, are sticky, and they cause those red cells to get stuck together and form those rouleau patterns. But in order to establish a definitive diagnosis, we will need to do some additional testing. We might start out with a BUN creatinine or a renal panel. We might look at calcium, serum calcium. We may test the urine for Bench-Jones proteins. And remember, those Bench-Jones proteins precipitate out at 56 degrees Celsius. They dissolve when boiled and precipitate out with cooling. That says cooking. I don't know why, but cooling, not cooking. And the normal proteins would denature once heated and would not precipitate back out of solution. But in the case of Benz-Jones proteins, they don't denature in the same way that other proteins might. Another big clue would be a protein electrophoresis, and we would be looking for that M spike in the gamma region of the gel. And if we were to see that gamma region M spike, we might reflex into an immunofixation electrophoresis to tell us what kind of monoclonal gammopathies are present. So again, depending on these results, I would suggest that I would think that the most probable diagnosis based on the information that we have could possibly be multiple myeloma. But really the only way to know that is if we do a bone marrow and we look at the look for plasma cells and do flow cytometry. That's going to be really the gold standard. Okay, our last case study, number 11. A 51-year-old male was seen in the ER for an injured wrist. The physical examination revealed an elevated blood pressure. Well, he is 51. It's possible he just has elevated blood pressure. His white blood cell count is 14.32. His red blood cell count is 7.2. Hemoglobin is 21.5. Hematocrit is 64. MCV is 89. MCH is 30. MCHC 34. And RDW is 17.2. Patient also has a platelet count of 500. The differential showed an increase of bands and polys, and follow-up testing revealed an increased total blood volume, increased red blood cell volume, and a decreased erythropoietin. So that's kind of weird. Why would we have such an elevated red cell count and hemoglobin hematocrit and white blood cell count and platelet count if our erythropoietin was low? So again, what does the data suggest in this case? Well, based on the red blood cell count, the white blood cell count, the hemoglobin, and the hematocrit, and the platelet, we know that there's one condition that affects all of those to some degree, but with a greater proliferation and dominance of that red cell proliferation, and that is polycythemia vera. It's specific to primary polycythemia vera, and primary polycythemia vera is due to a cytogenetic abnormality in the JAK2 gene like a mutation in JAK2 gene. So we are going to want to confirm that suspicion with cytogenetics to see if that JAK2 gene mutation is present. Now, the JAK2 gene mutation may be present in other conditions, but those conditions are not predominantly red blood cell proliferation, and you might see only about 50% of cases, for example, like in essential thrombocythemia, where the JAK2 gene mutation is associated. But in polycythemia vera, it's in almost all of the cases where we have that JAK2 gene mutation. Remember, I always remember it like this: the JAK2 gene mutation hijacks the bone marrow so that it is no longer has to be stimulated by erythropoietin and continues to stimulate the bone marrow to facilitate red blood cell, some white blood cell, and some platelet proliferation with a red blood cell predominance. Unfortunately, this leads to a higher blood volume. It can increase things like blood pressure, headache. It maybe even this person could be at a higher risk for thrombosis. There are quite a few things that overall is pretty it's not really a fun thing to struggle with. So what are we going to do? How are we going to treat this patient? Well, we may do therapeutic phlebotomy. That's going to alleviate them from that that hypervolemic state. Obviously, we can't use that blood for donation, but it can be therapeutic and alleviate the problems that the patient is suffering from. And if we have a very, very elevated white blood cell count, we might even use myelosuppressive drugs. But for the most part, that therapeutic phlebotomy is going to be very helpful for the patient. So that concludes our white blood cell case studies. If you have any questions, please, please, please feel free to contact me. I really want success for all of you. If there's anything you don't understand or that you're really struggling with, don't be shy. Just email me. We can talk about it after class. But yeah, I hope you guys study hard, take care of yourselves, and have a wonderful day.